The challenge with hospital care is that, at least in the United States, we're spending way too much money on care for the quality that we're receiving for the money spent. And so most of the improvement efforts have a real clinical focus. So what the emphasis is what are the known best practices that lead better clinical outcomes, and how can we make sure that they're implemented in all of the hospitals? And conversely, what are practices that haven't been shown to lead to good care? And let's make sure that people aren't wasting time and money doing processes that aren't shown to be effective. That tends to be most of the emphasis in the policy, at least in the United States, which is basically, very high-level organization. Are we choosing to do the right things or not? And at least from my read of the literature, there is much less emphasis on what about the person on the front lines of care. So how does the daily actions and activity of the people providing care, how does that impact quality, safety, and efficiency? And that's what I'm going to talk about today. So what I hope to convince you over the course of the hour that we have together is that there can be real benefits to having an integrated system where we redesign the work routines so that what the job of the everyday person is doing is actually meeting the needs of the patients in the hospital at that time, as well as coordinated across the different departments and disciplines within the hospital, and that there's infrastructure and processes for improvement by the frontline staff so that the staff can work together, contribute their idea, and improve the way that the hospital operates. And I am, at the moment, focused on hospital care. So this is probably too small for you to read it, but I'll talk you through what happened. So this is a very nice comic strip that I didn't draw. I wish I was this artistic. But the people that I worked with at Kaiser Permanente in their innovation consultancy, they drew out a script of what we observed together. And so this is an example of a person who got TPN, which is total parental nutrition, and at the end of the story. But starts out, the patient receives a surgery. It's a bowel surgery. And the patient starts out on IV fluids and antibiotics with a single pump to deliver those. And the patient goes up to the med-surg unit. What happens next is very predictably for this kind of surgery that the patient has. After 3 days, because of the limited bowel mobility, the surgeon writes an order for the patient to start receiving this intervention nutrition intravenously, because their gut's not back to working yet. And so the nurse that I was following said, this is very predictable. It always happens with this kind of surgery. So in comes this new order. And lo and behold, as the nurse looks at the order set, she realizes that now I need to change out the intravenous pump. Instead of having a single pump, I now have 3 kinds of IV fluid, so I need to get a triple pump to deliver this medicine. So she goes to where it's supposed to be, these triple pumps, which is the clean utility room, and looks in there, and of course there's no triple pumps, right, where they're supposed to be, no pumps. So then she says, well, let me look in the dirty utility room. Maybe there's a dirty pump in there, and I'll just clean it. And this is despite the fact that there's a department within the hospital, sterile processing department or SPD, whose job it is to clean these pumps and bring them up to the unit. But the nurse says, if I can find one, I'll clean it myself and use it on the patient. But there's none in there either. So then becomes the hunting and fetching, where she begins looking in every single patient's room to see, is there a triple pump in any of these rooms that's not being used? And she looks until she finds one, then cleans it, brings it to the patient's room, changes out the single pump, puts on the triple pump, and then has to bring the single pump that's now dirty to the dirty utility room. So that's everything that happens. And so what I'm proposing to you is that this is the kind of internal supply chain problems that I'm going to talk to you about today, where collectively the different departments were not working well together. And in fact, the patient had about at least a 10-minute delay in getting this nutritional fluid started because the nurse didn't have the right equipment to deliver the med, as well as it was very time-consuming and frustrating for the nurse to have to go on this hunt and fetch. And you could estimate anywhere between 35 to 50% of that nurse's activities in that film strip that I showed you was what I would call waste, which is if at the beginning of the surgery they had predicted that this patient, given the surgery, most likely is going to need a triple pump, and started the patient on a triple pump to begin with, all of that searching and hunting and fetching would not have been done. So that's my proposal. So what do I mean when I say an internal supply chain? So this is a depiction for the TPN internal supply chain. So this is operations management kind of lingo, and my guess is probably a lot of you aren't from that discipline, but it's just a fancy term for saying what are all the different departments that collectively are responsible for moving the material, the triple pump, the TPN, the order, all the way through from when the physician writes it for the patient to get it so that the patient actually receives the fluid at the right time and the right amount at the right place. And so these are all the different departments that are involved. So as you can see, there's a lot of them. And it's very similar kind of supply chains for things like medication, surgery, all those things. And so it starts out with the physician writing an order. That goes into a computer system, which is maintained in part by engineering, so engineering's involved. Central supply has to bring certain kinds of tubing to administer the TPN. That needs to be on the nursing unit. Dietary is involved in terms of other nutritional needs for the patient. The pharmacy brings up the medicine. Sterile processing is responsible for cleaning and supplying the pumps. Biomedical engineering makes sure the pumps are calibrated properly and are delivering the right amount and that they're not broken. The nurse kind of collects all of those things together and then is ultimately responsible for making sure that the patient gets the meds. So when I say internal supply chains, I mean all of those departments working together well and effectively to meet the needs of their patients. So there has been some research done on this which suggests that the kind of problem with the triple pump that I outlaid for you is all too common, at least in US hospitals. I have not studied any hospitals in the UK, but I have no reason to believe that it's any different, right? Which is, on average, nurses experience at least one of these problems per hour. And I should say, because I'm not a clinician, when I did my studies, I was just looking at things that were obvious to me, which has got to be an absolute low bar on the problems, because I was unable to see clinically related problems and issues that arose. So I'm quite confident that it's at least 1 to 2 problems per hour, probably upward to maybe 5 or something like this. And those, I call these operational failures, but they're basically small-scale problems. Things like broken, missing equipment, medication, information. And the response, overwhelmingly, is a heroic workaround. So what the nurse did in the film strip I showed you was a heroic workaround. You know, she was going to look everywhere in that hospital to find the triple pump that her patient needed to get the TPN. So rise to the occasion, do whatever it takes to deliver the care. But once the triple pump is found, the nurse doesn't expend any additional effort to try to fix it or prevent a triple pump from being missing tomorrow. Right? So that's sort of the workaround approach, is you take care of the immediate situation, but there's no investment in trying to make the system better the next week. I've studied nurses, but whenever I give my talk to other disciplines, it resonates with them. So physicians see similar kinds of things, different types of problems, but the same issues, as well as other kind of support staff in the hospital. So normally by now I've had at least one question or comment, because this is actually quite controversial, what I'm telling you, right? Which is, some people say, but gosh, Anita, you know, life is difficult. Like, this is a hospital we're talking about. Like, what is the big deal? These are just tiny little things, and why are you making a career studying these insignificant small problems that can be worked around in all of 2 minutes to 3 minutes, and near as your data show, have never killed anybody? Don't we have bigger, more important issues to solve in healthcare? But maybe you guys are all too polite to voice that kind of skepticism. Still, you guys are really quiet. Still no takers. Okay. All right. So what is the current state? So my proposition is that healthcare really has a hero culture, where these kind of workaround behaviors are valued, appreciated, and actually will get people promoted. So lots of studies that I've seen show that people actually hoard equipment, and they become the go-to person. So you know that this nurse on this shift will be able to get the equipment that's needed. The most egregious examples I've seen are in a case study written at the Stanford University hospitals about their surgical preparation units. And it goes so far as surgeons will actually take the equipment they need for surgery and keep it in their trunk of their car so that they know that they have the equipment they need to do their surgery. Of course, that means that piece of equipment is not available for everybody else to use. And so what happens is they end up having something like 5 times as much equipment as they really need, but they don't necessarily know where it is, and they don't have control over it. So these kind of hoarding behaviors are quite common. And I was interested to find this article that talked about US Army nurses in Vietnam. And they called it field resilience. And it was celebrated, which was, what is the creativity and ingenuity that the nurses in Vietnam had to use to figure out how to do surgery when they really didn't have the proper equipment? And so what I want to say is there's a good side to the workarounds, right? Because at the end of the day, the patient gets the care that's needed. So I'm not meaning to say that there's anything wrong itself, but it's just the fact if that becomes the de facto way of life and the system never gets any better. It's the lack of learning that concerns me, not necessarily the creativity and commitment that the nurses exhibit when they're doing these behaviors. And so some of these quotes are interesting to me. You know, jury-rigged, improvised, filched, bartered, and borrowed with the single intent of improving the quality of care. And then she was a magician, capable of producing virtually anything out of almost nothing. So you see that this kind of culture has existed for a long time, at least among the US nurses. But there is a negative side. So some of the research has shown that at least 10% of the nurse's day is spent on workarounds. And I would argue that that's 10% that could be spent doing more productive sort of patient care needs. And I tried to estimate what's the cost. And I came up with kind of a rough back-of-the-envelope calculation of about $100 on average per problem. So if you calculate that out, sort of given all of the nurses in the United States, kind of how much money collectively is spent on this, it turns out to be a pretty big chunk. Again, this is controversial, I think, in a way of what can they do with those little scraps of time? You know, can you make a quilt of patient care out of the 2 and 3 minute scraps of time that people are spending on these workarounds? And I would argue yes, because the nurses that I observed, they did a substantial nursing care task in 2 minutes. So in 2 minutes, they could get something done.
Can I argue there's a bigger point in there as well, because things like equipment not cleaned properly has impact on infection rates and other things falling out of it. So that could be hugely
Yes, I agree. I did try to take into account sort of clinical risk, but I agree it's probably very much of an understatement. I agree.
So can I just make a comment?
Yes, of course.
Just a few points, a few observations. I think the first one, when you talked about people working around certain issues, I think that's partially a reflection of human nature. There is people who do whatever it takes for their patients. But also with the rise of litigation on both sides of the Atlantic, if it's your responsibility, you'll do whatever it takes, as long as it's your shift. I think the broader point is one of organizational culture, which is that managers like people get things done, rather than people are going to raise problems. So yes. In a sense, it reflects the differences or the issues with regards to human nature and organizational culture as well.
Yes, I agree completely. Good points. Thank you very much. Okay, so that was kind of my dissertation. So then the question is, okay, so why are all these things happening? Why do hospitals have a bunch of these problems? And what do we need to do to try to remove the underlying causes so they don't happen again? And I think it's difficult. And so this graph here is data from my observations. And on the x-axis are the categories of what are those kinds of problems that I observed. And the y-axis are how many minutes did the nurse spend working on that problem. And the point I want you to take from this is as you look at that distribution of causes versus impact, it's what I would call long-tailed, which is the nurse would have to solve 60%, around 50% of those different types of problems in order to get an 80% reduction in the time spent on issues. That's the star on the graph. And as an industrial engineer, I was taught the Pareto Principle. Has anyone else heard of the Pareto Principle? Yeah, right? Which is this belief that there's 20% of the problems cause 80% of the impact. And so what the key is to process improvement is being a good detective to figure out what are those 20% things, the high leverage causes, if you will, that if you took care of those, you'd have a disproportionate return on your investment. And I was puzzled, right? Because I thought, this doesn't look like the 80-20 rule to me. And of course, people, as soon as I show this slide, hands shoot up all over the place, and people say, well, Anita, it's because you have the categories wrong. If you analyzed it a different way, I mean, those are causes. Maybe if you really dug down into it, you'd find that there is this 80-20, and you've just done your categorization scheme wrong. And so then I said, OK, I totally agree with you. So I went to an established categorization scheme. And so this is the Joint Commission on the Accreditation of Healthcare Organizations, which is the organization in the United States that inspects hospitals. And hospitals are required to submit to them their data anytime they have a sentinel event. And so I said, OK, JCAHO has established categories of what are the underlying causes of sentinel events, and let's look at those and see if there's an 80-20 rule in these. And so you look, and there's not an 80-20 rule in that either. It's 60-80. You'd have to address 60% of the causes to get an 80% reduction in this. And so my main point is just this, which is that at least what I'm seeing in these frontline problems are they're 23-minute problems, quite literally. These problems take on average 3 minutes to solve, 20 different types of them. But most of the process improvement literature techniques have been designed with the impression that there's one 60-minute problem out there. And so what I think is happening is that managers are getting, I don't know what the analogy is in Britain, but managers are getting the pitches in, and they're saying, too small, not worth it, too small, not worth it, too small, not worth it. But at the end of the day, that's just what it is. So everything is deemed too small, and you end up with 23-minute problems because they're waiting almost, if you will, for a mythical 60-minute problem that doesn't exist. And I've thought a lot about why might this be? Why might healthcare be different than manufacturing, where the Pareto Principle was originally developed and discovered and sort of propagated throughout the literature? And I think that it's because if you think about manufacturing and product defects, it makes total sense to me as an industrial engineer that you could have a machine that something goes wrong, a belt breaks, something breaks, and as a result of that, it's spitting out a bunch of bad product. So what you need to do is you need to find what part of the machine broke or is out of caliber, go in and fix that, and then the machine is going to stop producing defective products. So the 80-20 makes total sense to me when I think about it in terms of a machine making product. But if we think back to the slide that I showed you about internal supply chains in hospitals, and you think about each patient has its own unique care that that patient needs, and for that patient to get the care that's needed, all of those different connections have to work. Not only does the person within the box doing their activity need to do it correctly, but the connection between the two boxes needs to be functional and right. So it's not surprising to me, if we think back on that diagram, that any one of those parts could go wrong, and could go wrong in a unique, idiosyncratic way for that one particular patient. It doesn't mean it's going to keep happening over and over again. Maybe that particular conversation between two people, some piece of information was left out, but it's not necessarily going to be systemic and happen all the time. That when I think about it like that, it makes sense to me that the causes of these breakdowns on the front line would be more disparate, would be more spread out, because it's not a machine that's producing the healthcare. It's actually a network of a lot of different people doing a lot of different things. Okay, so what did I do? So my research was similar to some research that Kaiser Permanente, which is a large integrated healthcare system in the United States, had done, and specifically a group called their Innovation Consultancy. And the Innovation Consultancy got trained by IDEO, which is a design firm in California that was responsible for designing the mouse and other sort of very known products. And what they're famous for is they're famous for doing user-centered design. So rather than starting with the designer's idea of what the product needs to be, they go out and they see what is the latent needs of the people who are going to be using our product. So they observe the customers, they see what their needs are, they sort of live with them for a while. And so Kaiser Permanente uses these techniques to redesign their processes in their hospital. And so we used this ethnographic, user-centered method to go out and find out what is happening, what are the causes of underlying, the causes of these problems that we're seeing. And so you can't really see it, but that's me there, sort of on the hospital unit. And these are two other people. They made us wear these red kind of scrubs while we're on the floor all day with the care people. And so we basically, what was really nice about this was now we were a team of 26 different people. So the thing to take away is we were able to be in all parts of the hospital. So we were able to spread ourselves out across that supply chain that I showed you to figure out what are the issues that are happening on the nursing unit and what's causing them. What are the activities that are going on in the departments that supply them that causes these issues to happen. And this is just a picture to show you how we analyze the data. So we identified from our transcripts what are the ideas that come out of it. Each idea gets a sticky note, and we spent 2 weeks, 2 of the most torturous weeks ever, kind of rearranging these 780 Post-it notes to figure out what is the underlying themes and connections between everything that we saw. And these are the results that I'm going to present to you today as the results from these studies. Okay, so first of all, what we learned was that the principles of work design can be very helpful in preventing problems from occurring in the first place. And by work design, I'm primarily drawing on the article by my 2 advisors, Steve Spear and Kent Bowen, who went and studied the Toyota production system. And they distilled, it's called the DNA of the Toyota production system, and they came up with some rules in use, they're called, that I'm going to walk you through now that are the principles of work design. So this is a very skillfully drawn, you can tell what I drew versus what the IDEO designers drew, right? You can see the difference. But this is the sterile processing person who cleans the TPN pumps. And this feeds them to the nurse who then uses them on the patient. So the first thing that they talk about is activities, right? So that the activities of a person should be well defined. So you know exactly what work you need to do, whether you need to do it or not do it. Yes, no, very binary. And there's a way for you to check the output of your work to make sure that you've done it correctly. And we did find, so it's basically standardized work. We did find that this was a leading cause of the kinds of issues that we saw in the hospitals. Basically, problem work got propagated through the system. The next thing they talk about is connections. Connections, quite simply, are how do you request what it is you need from your internal supply chain partners. So you need something delivered, in what quantity, what type, and by when. So that's the dotted arrow is always information. So the nurse sends some kind of information to sterile processing, and then sterile processing, and this is the important part in connection, that sterile processing would send a connection back that said, yes, I got your request, and yes, I can deliver it to you. You should expect it by this time in this location. And so it closes the loop, and so people know that this works. So the best way that I can tell you about the lack of this rule being used in healthcare is to give you an example from medication administration, because I see this all the time. It works like this. A nurse needs to deliver a med for a patient. So, and I say she because the vast majority of the nurses that I shadowed were all female. So the nurse goes to deliver a med for the patient, looks in the drawer, med's not there, right? So then the nurse calls up to pharmacy and says, oh, the med is missing from this patient, can you send it to me or whatever? Or sends a fax down, send this med up. What's missing is this communication back. Pretend this is pharmacy, back to the nurse. So the nurse doesn't know. Did the pharmacy get my message, yes or no? Can they send it up to me, or maybe they're out of stock, or maybe it's not in formulary, is there some bigger problem? Doesn't know if they got it, doesn't know if they're going to be able to fulfill it, and more importantly, has no idea when it's going to come up. Is it going to come up in the next 10 minutes, or is it going to come up in the next 2 hours? So what proceeds to happen as a result of this lack of connection is the nurse has to look in the 7 different places that medication is stored on the unit repeatedly for the next 2 hours until she comes across that med. right? Because she doesn't know where it's going to be, how it's going to come up. Is it going to be in the pneumatic tube? Is it going to be in the patient's drawer? Are they just going to leave it in the pharmacy? Is it going to be in a Pyxis machine? Is it going to be in the refrigerator? So she has to keep looking. Now, the other thing that happens is because the nurse doesn't know whether the pharmacy got it or not, what does she do? Sends down a second fax, right? So haven't gotten it for 30 minutes, let me send it again. Now on the pharmacy end, the pharmacy now has 2 pieces of information for the same med. So they have to figure out, is this 2 different orders or is it the same order twice? And so I just wanted to illustrate, although these rules sound very simple, and I must admit I've read this paper like more times than I'd care to admit, I didn't really understand the nuance of it until you sort of see it in action and you say, oh, that's because they don't have the communication rule and these problems are happening. So this, I think, is a really big deal in healthcare because most of these internal supply chain systems I've seen do not have that closed loop information coming back, and so you get this ambiguity of, am I going to get it? What time am I going to get it? And where is it going to be? Okay. The third rule is about pathways. So we've talked about people's work, connection between people. This one is, how does the physical material actually flow through the organization? And basically what they found is that it's most effective if it's in sort of a straight line with no loops and forks and anything that creates ambiguity about where it could be and where it has been. And so basically, for those of you who are OR people, this is really fascinating. Believe it or not, this is the most fascinating thing ever for you, Paul, because basically what they're saying is we're giving up the benefit of pooling. Rather than saying that this piece of equipment or this person could be processed by the next available one in a bank of 3, we're going to have a designated person who's responsible for that unit at all times. And so even if other people are busy and whatever, you've got a pharmacist who works with nobody but your unit. And so you know if you have a problem, it came from that pharmacist. You can work with that pharmacist. You've got a partnership, and you get better communication and better problem-solving capability because you've got traceability and good communication and coordination. So they're giving up the benefits of pooling, of next available, to go with the problem-solving traceability of having dedicated resources. So it's way more exciting than my pictures can do justice. And then finally, the fourth rule is about improvement, which I have come to believe that Spear and Bowen were quite ambitious, because basically what they assumed was that there is any improvement going on at all, right? And I did not find this to be the case, at least in Kaiser Permanente. But they're assuming, given that there's improvement, it should be done at the lowest possible level in the organization and under the guidance of a coach, of somebody who really knows how to do process improvement, and they're going to coach the frontline people on how to do it and the techniques. So I found there was not even any of this going on at all. So let's start with zero, ground zero, which is you should do it or have the capability of doing it. So those are their 4 rules. And what I did was I took the 120 problems that we observed at Kaiser and sort of overlaid them on these rules. And what I saw was the ones in blue are the ones that fit the 4 rules that I just told you. And the red and white hash marks are things that didn't really quite fit under the Spear and Bowen rules in use. And it kind of makes sense to me because, again, these rules in use came from manufacturing. There's been sort of like an inherent feeling from people in healthcare that, this doesn't feel quite right to me to take TPS, which was developed for car manufacturers, and apply it to caring for people in hospitals, right? Like, it just doesn't feel right. And I would suggest that they're right, that it actually doesn't totally map onto. And I would argue that it's because of the unique, you have to deliver totally tailored, personalized care to patients, right? And so most of the problems that I saw that were outside of their scope was because things weren't being done for specific patients. And I'll get into those in a second. Okay, so this is what I'm talking about today. So this is sort of the meat of what I wanted to talk to you about. That was all just a setup. But this is, what do I mean by well-integrated internal supply systems, and why do I believe that this is what's causing so much of the chaos on the front lines of hospitals? And so first of all, activities. So remember, I stepped through what those 4 things are. I'm going to step through them again, but this time personalize them for healthcare. So activities, it's not good enough to just do activities that are well specified, yes, no, and you get feedback about whether it's right or not right. The activities actually need to be done to meet the needs of a patient. Because otherwise, these workers are doing work that might actually not be what's needed on the patient care unit. And this is exactly what happened in the TPN example that I gave you. That biomed sterile processing person, he was working really hard. He knew what to do. He had a standard process for cleaning the pumps and bringing them up to the unit. He knew if he'd cleaned it right or not. But he wasn't cleaning the pumps and supplying the pumps that the patient actually needed. Right? So all of the work, he was cleaning single pumps when what the patient actually needed was a triple pump. So that's my proposition here, is that if these supply chains are doing work, but it's not connected, if they don't have the information of what do our patients actually need, and they're just doing work, they might be doing work that's actually not what the patients need, and that creates the disconnect for the nurse when the nurse goes to deliver care. The second thing is connections. I found that there was a need for what Paul Carlisle calls knowledge translation across disciplinary boundaries. That is, these different clinical and even non-clinical groups have a language all of to themselves and a knowledge when they see something. And you don't know what other people don't know. And so they weren't telling and passing pieces of information from pharmacy to nursing that nurses needed to be able to find the medication quickly, because it was so obvious to the pharmacy. They didn't even think to tell the nurse this, and I'll tell you that story in a second. The next thing was pathways. This, to me, is by far the most interesting. As an industrial engineer again, as I traced these processes through the hospital, it turned out that there was really big gaps where equipment would stall in between the department boundaries. And literally, each department thought the other was responsible, and that piece of equipment would just stay there for weeks. And no one sort of pushed it along or pulled it along because they all thought the responsibility lied somewhere else. So there's gaps in the process. Even if they're linear processes and improvement, my argument is that hospitals really need to have infrastructure to enable problem solving and process improvement for processes that cross departmental boundaries. So if we stick with my TPN triple pump example, that triple pump, in order to deliver TPN, that process crosses multiple departments. And yet Kaiser had no processes, nothing in place, no infrastructure for sterile processing, dietary, physicians, and nurses to come together and figure out, is the process we have for administering TPN to patients, is that working as well as it could? There's no forum for them to come together and talk. Each department had their own meetings, their own measures, and they thought that the sum of the individual parts would make a functioning process at the end. Okay, so activities. So again, so now I double click on each one of these. Is that okay? Is that right? So activities. Activities, again, my proposition is that activities only add value if they meet the patient's needs. And this is not anything new. This has been in the lean literature forever, right? Which is that the pull system, you do what your customers need and only adds value if it's what customers need. So this is a representation of the TPN example that I gave you. And these things here are different patients. And the different colors and different head patterns symbolizes that the patients have different needs for equipment. And so this blue patient needs something. This is the pumps that the nurse has in stock on the unit, so no blue pumps there. And this is what sterile processing is working on currently, right? So the sterile processing department cleans dirty pumps and stocks clean ones, but it's not triggered in any way by what the patients need. They're literally taking what's in the dirty utility room, cleaning them, and bringing them back. There's no link, no connection at all to what are the diagnoses, the DRGs, the medicines ordered, the equipment needs of the patients. There's no link there. So this patient, again, has the order for TPN, and it requires a triple pump. And the nurse discovers this gap or this mismatch between what's supplied and what's needed at the moment she needs to give the TPN. So this is why, this was like a huge aha for me. Because I was like, this is why everything is a crisis and everything is firefighting, is because these gaps are not discovered until you need it right then. And then you realize, oh, I don't have what I need, because it's all a discovery process in the moment. And so my proposition is that these kind of problems are going to happen on the boundary of departments that do supply to stock, and that's kind of an operations term for, you know, you need 5 single pumps and 3 triple pumps, and just clean them and bring them up, and if they're not there, bring up one to replace the one that was used. So you're not linked to the actual end needs, you're just stocking up to a certain amount. And then units that do supply to order, right? So the nurse has to deliver what's actually needed. But there's no link, so what they have supply to stock here isn't necessarily going to match what patients actually need. And so there's a gap there, and the nurse has the unfortunate job of sitting on that gap, which is why so many problems and workarounds happen at that interface, is because they are at that make to supply to stock versus supply to order. And so they find those disconnects. And the more variability you have in your end patient needs, the more likely this supply to stock system is not going to work, right? And I actually have some data from Duke University Hospital that suggests that this is true. But what's really sad to me is in the nursing culture, that unit gets blamed as being a bad unit, right? Why do they have so many problems? They have a renegade workaround culture, when in fact, I would argue that it's systemic. They have a large range of DRGs they're caring for, so they're not likely going to have their needs met by the supply departments. Okay, deliberate knowledge transfer. Good connections require transfer of knowledge, but also translation. Turn it from what is knowable by one discipline into something that's readable, legible, intelligent to the other discipline. And so this is my example. So as you look at this, for those of you, do we have any physicians in the room? One? Okay, great. You'll have to. And you?
No, I'm a gynecologist.
Okay. All right. So this is actually orders, right? So the whole point of this is to show you it's not real obvious what equipment you need based on this set of orders. So nurses could look at this set of orders and say, okay, this one here, I'm going to need an IV pump to deliver this. This one is ultra intravenous, so I'm going to need an IV pump. Oh, an insulin, intravenous. Okay, so I have 3 intravenous meds, I need a triple pump. So that's what I mean by knowledge translation, right? A knowledge translation would be, oh, for sterile processing department, the translation is IV pump. This big complicated medical order means you need an IV pump, and you need 3 of them. Okay, so this is what the nurse does. Nurses can translate the medical clinical orders into equipment needs. And near as I can tell, they're like one of the only people in the hospital that are actually doing this role. I presented this last week to some physicians, and they said even when they write the orders, they're not thinking about what are the equipment needs. They don't even know. And the example that they gave is they said, you know, gosh, I could change my order setup. I could order a different medicine. I could do it differently. But it didn't occur to me that it had this implications for the materials and equipment that the nurse needed. And so just another example of the need to translate this knowledge and then transfer it and give it to the people in other departments. But the sterile processing department, who are the people responsible for supplying pumps to the units, they're not given the medical orders because they don't need to know, apparently. And even if they had them, they wouldn't be able to understand them and read and know, oh, that means this kind of equipment things. So when you think about it this way, you think, oh my gosh, at least for me, I was totally floored by this. This department is responsible for supplying equipment, and they have no idea what it is that needs to be supplied, right? And that knowledge does exist in the organization, but nobody thinks about the fact that if we took a little bit of time and figured out what are the standard order sets that these kind of conditions have, and these are the equipments they need, you could proactively begin working on making sure that the right equipment is in the right place at the right time. But currently, it all gets discovered at the last minute when care goes to be delivered, and no wonder why people are encountering these kind of issues all the time. The other choice, right? The other choice is you just stock a whole bunch of stuff on the unit. You just stock tons of everything so that the nurses can sort of bricolage and pick and choose what they want. And I would say that's the approach that healthcare has used in the past. And I think it has worked in the past because care was maybe simpler. There were fewer meds, fewer equipments, fewer specializations, so you only needed some generic things and that would work. My argument is healthcare gets more complex, more tailorized to the patient's needs. You don't have enough physical space on the nursing units to store all the possible combinations of things that you need. And also it's expensive, right? It's expensive to have just tons of everything because you don't really know what you're going to need. And that's sort of the alternative. So what happens is what happens, which we see, which is that you kind of have some smattering of stuff, but you're never going to get it completely right. But the nurses are really good at working around, so we kind of hobble through with that crutch. OK, pathway. So equipment installed at the boundaries. This is best shown through an example. So what I'm going to talk about is what's called a Dynamap. Does that mean anything to anybody here? Dynamap? Yeah. So it's on wheels. So picture me wheeling my Dynamap. It's this nice little baskety thing that has everything I need to take the vital signs for my patients. It has a blood pressure monitor, temperature probe, and pulse oximeter, which takes the oxygenation levels of the blood. So it's my little piece of equipment I need really badly to do my job, especially when I first start my shift. So on this unit, there were 3 non-functioning Dynamaps. And by non-functioning, I mean they were missing something. So they were missing the blood pressure cuff, or they were missing the temperature probe. So I could do maybe 2 of the 3 things I needed, but then I had to go get a different Dynamap to finish my vital signs. So there were 3 of them that were missing. Now, just a little side story I have to tell you. These Dynamaps were so important to the nurses and in such short supply that the nurses would come to work 30 minutes early to lay claim to one that fully worked, because it made such a difference in their day. Now, they were not supposed to do this, right? This is so against policy, because these are shared resources that you're just supposed to use when you need it, and when you're not using it, you're supposed to put it back. But they would tape their names on it, they would put personal things on it, they would claim it for the day. So these kind of behaviors are in response to what I'm going to show you. And it was so bad that 2 nurses got literally in a fist fight over a Dynamap, and one of them went home on permanent nerve damage, because they were fighting over these things in this process that I'm about to show you. So just seems like a stupid little piece of equipment, and why don't they just buy more of them? That is what you're all thinking, and what you're all going to tell me at the end, I know. But let's step through the process. So the process was, when this Dynamap wasn't working right, the nurses were supposed to fill out a pink tag, a little pink ticket, and the pink ticket would put it into the system so that the biomedical engineer could fix it. But the nurses got blamed because they never used the pink tickets, right? So you'd see these Dynamaps in the hallway, not broken, and you'd think, those lazy nurses, they never fill out the pink ticket. And why do they not fill out the pink ticket? Because they just grab one that works. So they don't need to fill out the pink ticket. They just grab one and they go, right? They're just short-sighted nurses. Keep that in your mind, and we'll revisit this at the end of my little story. OK, so when we were there, we actually took those and we made the process work. You know, we had them fill out the pink tickets, and then I followed it through the system. So here's what happened. It literally goes down to this person. This is a biomedical engineer, and he's got this beautiful office. Do you see all the stuff he has? Isn't that cool? He's got a lot of stuff. That's what you should keep in mind. This man knows his stuff and has it. And what he's responsible for is checking and recalibrating, you know, the thermometer. Does the thermometer probe give you the right temperature reading? Does the pulse oximeter give you the right, all that stuff? He calibrates it. So he took this piece of equipment, which was missing its blood pressure cuff and its thermometer. He recalibrated it by putting on a blood pressure cuff. There is no other way to test it. So he took out a blood pressure cuff, he put it on. He is so dedicated, he took his own temperature, right? He does it, what blood pressure do you think he does? He does his own blood pressure, his own temperature. He worked through lunch to do this for me. Okay? And he says, it works fine. He enters it into the IT system, and then what does he do? He takes off the blood pressure cuff, takes off the thermometer probe, takes off the pink ticket, and sends it back up to the unit in the exact same condition it was before. I'm not kidding you. No blood pressure cuff, no temperature probe. So it did nothing. So as a researcher, I'm not supposed to say anything, right? Like ethnographic, you're just supposed to be there. But I had to say, Why don't you put on a blood pressure cuff and the temperature probe? You know what they are. You have them right here. Don't you want to send it up fully functioning? Don't you feel bad? Because you haven't really fixed anything. And his comment to me was, anybody guess? Not my job. That's exactly what he said. He said, my department would be charged for the blood pressure cuff and the temperature probe if I did that, and our department budget would go way out of whack. And the nurse, that's the nurse manager's job. The nurse manager is responsible for putting on the blood pressure cuff, for ordering those, for having the spare parts, and that's better. You know why that's better, Anita? Because they're on the nursing unit 24 hours a day, 7 days a week, and by empowering them to do this fix, then they can fix it all the time, versus I only work Monday through Friday, 8 hours a day, and there's a large part of the time I'm not here, so it's better that they have that capability. And this is what it looked like when I brought it back up to the nurse manager, and I told her, he said that you're responsible for ordering these parts. Can you do it for me? Can you show me how to do it? And this is the example of knowledge translation as well, because she had no idea. What is the part number I need to order? What company do I order it from? There were, as you can see, there was multiple models here. There's, this happens all the time, right? Like this stuff gets upgraded. So she had 2 different models here. She's like, I'm not exactly sure which model, which blood pressure cuff. And to make it worse, one of them, you can't really see it, but one of them, it wasn't so simple. They had actually, whoever took the thing, had taken out the whole temperature thing. So you actually needed a screwdriver. It wasn't just as simple as putting in a probe. You actually had to buy a whole new unit and attach that on. And so if you think about this process, my whole point of telling this story is my story of the fact when I say there were gaps in the process, right? And that these pieces of equipment literally sat on the nursing units for weeks on end, missing parts, because the nurse manager there was nothing to trigger her that she needed to do this. She didn't have the right knowledge, the information about the expertise, if you will, to know what parts to order. The biomed person thought, not my responsibility, it doesn't have a pink ticket on it. And the nurses said, why pink ticket anything? Because it doesn't fix anything, right? This pink ticket system doesn't work. So literally this piece of equipment, even though there was a process, and it was a well-defined process according to Spear and Bowen, there was a huge gap that the machinery would just sit there for weeks on end. So what people always say now is, Anita, how much do these things cost? They must be less than $500. Why don't you just buy a whole bunch of them and make sure they're on the unit? And I say, that's great, but you're going to get something that looks like this. You order a whole bunch, you have enough, and then for whatever reason, they get broken and used up until they go down till there's none, and then you order a whole bunch again. Instead of being able to have a system like this, which would be a good process that could actually maintain these pieces of equipment, then you could have 8, 8, 8, 8, 8 at all times. Instead, that's why you have the peaks and the valleys and the peaks and the valleys. So that's just a very long-winded example about pathways and gaps in the process. And then finally, improvement. So department-level metrics. So this hospital, the 2 hospitals, they were very much department-level metrics. And we heard that in the story of the biomed. My department budget will be over budget if I don't do this. They're not thinking about the cost to the hospital, the cost to the system, the benefits of coordination across. And I think that this is really, really important because in healthcare, because of the interdependent nature, the cause of the problem is down here in the supply chain. If you were to fix it, it's going to cost that department money or make them change the way they do business, make them change their processes. They're going to bear the brunt of the cost, but the benefit is going to surface down here in a different department. And so what is going to make this department down here change and do something different and incur a cost if they're measured solely on just their department's performance and not on the system-wide performance? And the best example I have of this from a clinical perspective is sepsis, where Kaiser Permanente, again, one of the things they did was they were trying to reduce mortality from sepsis. And they discovered to do that, the emergency department people needed to start treating sepsis aggressively very early on and in the ED. The benefit showed up because now they were only spending 2 days in the ICU instead of 2 weeks. And they did have to move to looking at sepsis as a hospital and mortality rates at the hospital level because the ED needed a bigger budget, needed training, needed more people and more time. But the benefit was reaped by the ICU in the strict sense of the word. Okay? So what are the solutions? So right now people are usually very depressed by my talk, which is a very bad thing. So solutions. So what can we do? I think that this data is heavy in the sense of the individual employee, right, at the level, the actions and belief, the employees will always do the workaround because it is much cheaper, and it is actually better for the system that they do the workaround than don't do the workaround. And so it's a rational, logical choice that they'll make every single time. And as a result of that, the information goes down, because you don't hear about it because they were able to work around it, they were able to take the vital signs, right? At the department level, the budgets, my proposition is that these 10% inefficiencies are never bad enough that it's going to make a department be off a budget, which would then raise attention from the manager. So again, these things are happening, they're triggering. It's like a brain that's gone haywire. The synapses are triggering, but it's not triggering any kind of response or action. I also think, these things I'm talking about are not strategic. I don't think anybody could stand up here and say, this is exciting strategic things that the CEO of the hospital is going to do. No, what does the CEO of the hospital want to do? They want to enter new markets, start delivering a new kind of care, collaborate with the community healthcare system. They don't want to worry about the internal supply chains and something as trivial and boring as vital sign monitors. But yet, and also organizational structure. Again, designed around functions, not around processes and flows of care. So this is my proposition. This is a terrible slide. I'm sorry about the red. But if you have to change an organization like a hospital from basically being organized as a supply to stock system to one that's truly integrated and integrated across all those functions and meeting the needs of the patients, I propose to you that this is very similar to a disruptive innovation, like Clay Christensen talks about in terms of disruptive innovations. And I think it's like a disruptive process innovation. So I've come to realize over the years, I used to think quite naively that it was all about getting the nurses to speak up. If we could just get the nurses to speak up and not do the workaround, the logical engineers of the world like me would hear those problems and would fix them. I've now come to believe that it's much deeper, much more systemic. It's about, you have to change organizational structure, you have to change incentives, you have to change the way processes are designed, you have to change how many people you staff. It's going to be very, very difficult for existing organizations to do this. And that's why, if you think about it, I think similar to the way Toyota and Toyota's make cars to order rather than make cars to stock sort of disrupted General Motors, at least in the US. And similarly, Chipotle, which is a very popular burrito sort of fast food company in the US, is kind of disrupting a make-to-stock system such as McDonald's, right? And I think that it's a similar kind of disruption with healthcare. Can we figure out a way to have healthcare truly from all processes sort of delivering care to patients as they need it? So how am I doing on time? I should be over by now. Yeah?
How many slides have you got left?
All right, just a couple, I think. So this one is interesting to show in terms of another sort of issue that makes the data heavy on the individual level is that people don't perceive that it's a system problem. It's the fundamental attribution error, which you've probably heard about, right? Which is if something goes wrong, you believe somebody did something wrong, it's somebody's fault. Like people don't say normally, oh, let's work on the system, let's fix the process, right? So what happens is, this is an example, and I didn't share this story with you, but there was a horrendous missing medication story. And we talked to the pharmacy person about it, and they said this, the medication, it could be on a shelf in a bin in the refrigerator. Nurses don't know where the medication goes. They just call us because it's easier. So you can almost feel the blame, right? The pharmacy person isn't saying, I need to work better. Maybe the process of supplying meds to the unit isn't good. We could work together. We can make the process better. We could get medications to our patient factor. You're not hearing any of that. It's nurses aren't trained. They need to be trained. And that kind of belief stymies improvement because everybody thinks if we could only fire the bad people and hire good, competent ones, the system's going to get better, when in fact, the systems themselves, the processes are not working well. And this is just an example of the organizational structure. Again, if we take these pumps, and you see all the different groups that were involved in it, and they're under completely different organizational silos. So we've organized hospitals by discipline, and yet patients flow through them. This is nothing new, but you just can see it very visibly here. It makes it more difficult. So my proposition is that collaboration among internal supply chains, it's going to require active management of this system, not departments. And this is my fundamental difference. How my thinking has changed is this has to be something that the senior leadership wants to do, at a very high level and change the way the hospital is organized, change the way people think about their jobs. Because when I mention this kind of stuff to people in the hospitals, the first thing they say is, it would be too expensive to have a supply technician sort of restocking supplies during the day, sort of like the water bug approach. But then you step back and you think, how expensive is it to not have that, right? How expensive is it to run out of supplies, to run out of equipment, to not have what you need sort of day after day? And so if you think about improvement, like where is the improvement going to be? Now, after I'm done with this lecture with you, you can look at this and you can say, most people in a lot of sort of lean techniques, process improvement, people improve your own work routine. So you could imagine biomed, the guy cleaning those TPN pumps, or those IV pumps, he could get really good at cleaning them, right? He could work on his routines, he could be even better. Even the person who did the vital sign monitors, the biomed engineer, he could get really good at calibrating that piece of equipment and hone his thing up, but that is not going to solve our problem. Also, you can improve connections between departments. That might help a little bit, but yet my proposition is that to really make it better, you actually have to optimize the end-to-end process across departments. And only when you start looking at it as an entire process and saying the goal is, did the patient get the care that was needed in a timely way? And how can we work together across all of those to make sure that happens, right? That's the only time these improvement things, I think, are actually going to make a difference. So here's my last slide, summary. So I took you on a long journey of like 13 years of my life, which is kind of embarrassing that I've spent so long on this. But that these problems that I saw, they're caused by work design, by individual routines not being well specified. Lack of integration with patient needs, I think, is a big deal, that people can do work, but it's actually not what is needed by the patients at the time. And a lack of coordination and knowledge transfer across department boundaries. So that's what's causing them. Where do they happen? They're going to happen on these gaps between when the system is supplying to stock, because for whatever reason, they don't know what's actually needed, but you actually have to deliver personalized care. There's going to be a gap there. That's where these issues are going to happen and arise. And they're going to persist because this data is heavy. All of the forces in the organization are pulling down this information, so we don't really know how much they're happening. We don't really know how important they are, and they get glossed over. The way that I like to think about it is it's a built-in 10% inefficiency in the system that just like persists day in and day out, at least 10%, right? Extra equipment, wrong equipment, workarounds, and it just is going to continue to persist because that's sort of where it goes. And that the solution is going to require still not speaking up, even though I have a paper I'm presenting tomorrow about speaking up. It's deliberate redesign of work processes so that they're actually meeting the needs of the patient and that they're better coordinated across the boundaries. So that's all that I have. I'm sorry to lecture at you for the hour, but that's it. Thanks.